You know, dealing with abnormal uterine bleeding can feel like you're trying to solve a puzzle, but you're missing half the pieces. It can be confusing, frustrating, and honestly, pretty stressful. So, in this explainer, we're going to find those missing pieces together. We're going to turn that confusion into clarity. Let's dive in.
So here's our game plan. First, we'll nail down what DUB actually is. Then, we'll get into the science of the hormonal imbalance that's causing it. After that, we'll walk through how it's diagnosed, explore the different ways to manage it, and then wrap up with the most important takeaways you need to know.
Okay, but before we can really talk about what's abnormal, we need to get on the same page about what's normal, right? So what does a typical menstrual cycle even look like? This question right here is the perfect place to start.
All right, first up, what in the world is dysfunctional uterine bleeding, or DUB, anyway? Let's get a really clear, simple definition.
So at its core, DUB is when you have abnormal bleeding but there's no physical reason for it, like a fibroid or a polyp. It's what doctors call a diagnosis when everything structurally looks totally fine, and that points the finger directly at a hormonal imbalance. Actually, the name is a bit outdated now. You'll often hear it called AUB-O, which stands for Abnormal Uterine Bleeding from Ovulatory Dysfunction.
This slide really lays it out perfectly. A normal cycle has a certain rhythm to it, right? It comes every 21 to 35 days, and the bleeding part lasts for about 3 to 7 of those days. Anything outside of that, bleeding that's way more frequent, lasts a lot longer, or is just super heavy, that's what gets flagged as abnormal.
Now, you might hear some pretty specific medical terms thrown around to describe these different bleeding patterns. Think of this as your quick and easy decoder ring. Whether it's menorrhagia for heavy bleeding that's still on a regular schedule, or polymenorrhagia for cycles that are just way too close together, each of these words helps your doctor pinpoint exactly what's going on.
Okay, so we've covered the what. Now for the really crucial part, the why. Let's get into the nitty-gritty of the hormonal imbalance that's actually driving DUB.
And here it is. This is the main culprit right here. A whopping 90% of all DUB cases are what we call anovulatory. That's just a fancy way of saying that ovulation, the release of an egg from the ovary, didn't actually happen during that cycle. This is super common when your cycles are just starting out in adolescence or when they're winding down in perimenopause, because your hormones are naturally all over the place. Honestly, this one fact is the key to understanding everything else.
So how does not ovulating lead to all this bleeding? Well, it's basically a domino effect, a chain reaction. When you don't ovulate, your body doesn't get the signal to make a really important hormone called progesterone. Think of progesterone as the manager that keeps the uterine lining stable. Without it, estrogen just takes over, causing the lining to build up and up until it becomes thick and unstable. Eventually, it just can't hold itself together anymore and starts to shed in a really heavy, unpredictable way.
If you're going to remember one thing, let it be this. It's the whole issue boiled down to its simplest form. No ovulation means no progesterone, and that means no control over the bleeding. It's truly the most critical part of this whole story.
Okay, so if you're going through all of this, how in the world do you get some answers? Let's take a look at the diagnostic process. This is the path to finally getting some clarity on what's really happening inside your body.
Now, this is a really important idea in medicine. DUB is what's called a diagnosis of exclusion. All that means is that a doctor only lands on this diagnosis after they've carefully checked for and ruled out every other possible physical cause for the bleeding.
And what exactly are they ruling out? Well, it's a pretty thorough list. They'll check for things like pregnancy, any structural issues like fibroids or polyps, infections, and even bigger picture problems like thyroid disorders or issues with blood clotting. The whole point is to make absolutely sure nothing serious is being missed.
And this is what that exclusion idea looks like in practice. With DUB, everything looks normal. The physical exam is normal, and the ultrasound is normal. There's no visible problem to point to. But if that ultrasound does show something, like a fibroid, then boom, that's the diagnosis, and it's not DUB anymore.
So to do all this detective work, doctors have a standard set of tools. They'll use blood tests to check for things like anemia and your hormone levels. A pelvic ultrasound gives them a crystal clear picture of your uterus. And especially for women over 35, they might do an endometrial biopsy just to check the cells of the uterine lining itself. All right, once that diagnosis is confirmed, the conversation shifts to management, and the goals here are pretty straightforward. First, stop the bleeding that's happening now. Second, fix any anemia that's resulted from it. And third, regulate the cycle to keep this from happening again.
The first line of defense is always going to be medical management. This usually means hormonal treatments,
like taking progesterone or using birth control pills to fix that core imbalance. But there are also non-hormonal options that can help reduce blood flow, plus supportive care, like taking iron supplements to get your energy back up if you become anemic.
Now, surgery is usually only on the table if those medical treatments just aren't cutting it, or if a person is sure they're done having children. The options can range from a DNC to something called an endometrial ablation, which removes the uterine lining. And of course, a hysterectomy is the most definitive option because it provides a permanent cure.
Wow, we have covered a lot of ground. So let's take a second and boil all of that information down into the key things you should really walk away with.
First, I want you to remember this number: 90%. The huge majority of DUB is caused by a lack of ovulation. That means, at its heart, it's a hormonal problem, not a structural one.
Second, never forget that DUBA is a diagnosis of exclusion. And you know what? That can actually be really reassuring. It means your doctor has already looked for and ruled out other, more worrying causes. It's the answer you get after you've confirmed that everything else is okay.
Third, treatment almost always starts with the simplest, least invasive options. The game plan begins with medications to get that hormonal imbalance and the bleeding under control.
And finally, it all comes back to this one hormone, progesterone. In an ovulatory DUB, it's the absence of this key player that leads to all the chaos. And that's exactly why restoring it is the #1 goal of treatment. So we'll end with this thought. Understanding the why behind what's happening in your body is so empowering. It completely changes the conversation from "what is wrong with me" to "okay, how do we work together to manage this?" So with all this new knowledge, what's one question you're inspired to ask at your next doctor's appointment?